So now this point we discussed already. We'll go into thyroid surgery. So removing the thyroid gland, what is that known as?
Thyroidectomy.
Thyroidectomy.
Thyroidectomy, yeah. Indications, rose and collar position. What is rose position? The specific position for thyroid is rose position. Okay, and we give a collar incision. The position's name is rose position. So what is this part?
Isthmus.
Isthmus. Okay. So just listen once. Hemithyroidectomy is removal of one lobe and isthmus. One lobe plus isthmus. That is hemithyroidectomy. Total thyroidectomy is two lobes and isthmus. Two lobes and isthmus is total thyroidectomy. Okay. Subtotal thyroidectomy. Two subtotal. This lobe will retain a small part. This lobe will retain a small part. This lobe will retain a small part. Two subtotal lobectomy plus isthmectomy is subtotal thyroidectomy. Near total is one lobectomy, isthmectomy, and one subtotal lobectomy is near total thyroidectomy.
I'm absolutely lost. Could you please explain that again?
Yeah. So before that, what is this?
Retractor, which is
It's a self-retaining
self-retaining.
thyroid
Self-retaining
retractor.
retractor. What is the name?
Jody's retractor.
Joel's self-retaining thyroid retractor. Very good. Okay. So this is one lobe. This is other lobe, and this is the isthmus. Okay. Lobe 1, isthmus, lobe 2. Yes. So hemithyroidectomy. Hemi. One lobe and one isthmus. No doubt about this.
Yes.
Total thyroidectomy. Two lobes completely. Two lobes and isthmus. Yes.
Yes. Yes,
So
sir.
there is no doubt in these two.
Yes, sir.
Okay. So there is doubt regarding subtotal and near total. Subtotal thyroidectomy and near total thyroidectomy. So what is that? What is subtotal and what is near total?
Subtotal is two lobes, a part of two lobe and part of isthmus.
Yeah. No, isthmus completely will remove. In subtotal, lobe will retain a small bit. This bit is left. This part is left. The rest of the tissue is excised. This part is left. The rest of the part is excised. So this is a subtotal lobectomy, one subtotal lobectomy, two subtotal lobectomy, and isthmectomy. This is subtotal thyroidectomy. Okay.
Okay, sir.
Whereas near total is you excise the complete lobe here, one lobe complete excision, isthmus complete excision, and subtotal lobectomy on the other side. You retain this part and take it off. Take the other part. Okay, the shaded regions are left behind. Now is it clear?
Yes, sir. Yes, sir.
Yes, got it.
Yeah,
So the previous slide, just 1 second, sir.
yeah.
Okay.
Complications of surgery. What are the various complications of surgery? Thyroid surgery. Most common is hemorrhage. What are the various types of hemorrhage? What is hemorrhage?
Bleeding.
Blood accumulation.
Hemorrhage is bleeding. Okay.
Primary on table.
on table. Reactionary
is within 24 hours.
Okay. Secondary
is after 1 or 2 days.
Yeah. Why is secondary due to
Infection.
infection? Very good. So these three things: primary is on table, secondary is within 24 hours due to slippage of ligatures or knots, and reactionary is due to 24 hours, and secondary is due to infection. Okay. Hemorrhage is the most common complication because thyroid is very vascular. You have 3 arteries running like this and 3 arteries running superior, inferior thyroid edemas. You have both on both the sides. So there is high chance that there is bleeding. Lot of bleeding is expected. Okay, this is one complication. Second is injury to the nerves. There are 2 nerves also, right? External laryngeal nerve and recurrent laryngeal nerve. There is a small gland with multiple vessels and arteries and nerves. So whenever you do a surgery, there is high chance that you injure some of them. So external laryngeal nerve injury will result into hoarseness of voice. The patient will have hoarseness. Voice will be hoarse. Recurrent laryngeal nerve, if it is unilateral, 2 nerves are there. If only one nerve is injured, then it's okay. The patient will have only hoarseness of voice. If both of them are injured, then it is a bilateral life-threatening condition. What will happen if both the recurrent laryngeal nerves are injured? Can anybody tell me?
Aspiration.
Sorry?
Vocal cord will get into medialized position.
Yeah, vocal cords will get into paramedian position or cadaveric position, we call it as. See, if this is the wind space, air space, so these are the vocal cords. They have a space in between. But what happens when bilateral recurrent laryngeal nerves are gone? So both the vocal cords will approximate. So the patient will suddenly develop aphonia. He will develop aspiration, or it is very life-threatening. So you have to do emergency tracheostomy and you have to do it. Okay, so this is a life-threatening. So this is a very dangerous situation when we injure both the bilateral recurrent laryngeal nerves. Okay, clear?
Clear, sir.
Post-operative respiratory distress because of bilateral or there will be laryngeal edema. Once you have the larynx is there, on that the gland is there. Once you remove it, there will be huge edema or the larynx will become weak, known as laryngomalacia. There may be hematoma, tension hematoma. So all these reasons will cause post-operative respiratory distress in a patient with thyroid. Is this clear? What is hemorrhage? What is the nerve injuries? Clear?
Yes, sir. So primary is on time, or what is it, sir?
Sorry?
Primary, so it is on time, or what is it?
Primary is on the table.
Table. Okay, okay.
Table. On the table. On the operating table, if some bleeding is there, it is known as primary hemorrhage. Okay?
Yes.
Okay. So, look at this question. Patient underwent total thyroidectomy. On post-op day 4, sister in charge, while recording the vitals every morning, noticed the patient's arm in this position while checking BP. Why is it so? Any idea? Yes,
Nerve
no?
palsy.
Sorry?
Nerve palsy. Induced nerve palsy.
Nerve palsy or something else?
In total thyroidectomy, we remove parathyroid gland.
Very good.
So it leads to hypoparathyroidism.
Yeah.
This is Chavatsky sign.
Sorry?
Chavatsky sign.
Yeah. So, hypoparathyroidism. This is also an important complication. Nerve injury, vessel injury, we discussed. Nerve injury, we discussed. Respiratory distress, we discussed. Now, parathyroid injury. There is a vascular insult to the parathyroid gland. I told you in the first slide only. You have to ligate it very close to the gland. Okay? If you don't ligate it close, there is always a chance that the parathyroids get devascularized. Parathyroids, what is the function of parathyroids? Come on, what is the function of parathyroids?
Calcium.
Yeah, simple. Don't go into depth. Parathyroid, calcium metabolism. If parathyroid decreases, calcium decreases. That's all. Same, simple, one word, calcium metabolism. So what is the first, they ask this, what is the first symptom, earliest symptom? It is perioral numbness. The patient will complain of numbness, perioral numbness. Most of the times what happens is, in the ward we go, the patient will tell, I am feeling some numbness here. We'll tell it's okay. But that is an important sign. Earliest sign is perioral numbness and tingling. Okay, that is the earliest symptom. And there will be paresthesia, tetany, and if you leave it, hypocalcemia is a very dangerous situation. The patient will go into respiratory distress and he will die ultimately. So we have to act fast. We have to notice these symptoms fast, and we have to give some calcium supplementation. These are all the symptoms. The earliest symptom is perioral numbness and tingling, and the cause of death is respiratory distress. Whereas coming to the signs, Trocheus sign. So this is nothing but it is carpopedal spasm. The patient's carpopedal, this region goes into spasm, carpopedal spasm. Carpopedal spasm. 1 minute. It typically happens when we inflate the sphygmomanometer. It is known as Trocheus sign. And one more sign is there, Chostek sign. If you just tap it here, the muscles will go into twitching of facial muscles. It is known as Chostek sign. I think I have the image of it. Yeah. This is Chostek sign. See here. Chostek sign. This is also a sign of hypoparathyroidism. Okay. And how to do it? We monitor symptoms and serum calcium. We supplement serum calcium. We supplement calcium. And permanent hypothyroidism is very rare. Only 1%. Most of the times nothing will happen. It will recur. It will recover. But only in 1% of the patients they land into permanent hypoparathyroidism. Sorry, this is not hyper. It is hypo. Permanent hypoparathyroidism. So that we have to give them lifelong calcium supplementation. So can anybody tell me what only about hypoparathyroidism related to thyroid? Only this part. Every point I want.
So hypoparathyroidism is caused due to the vascular insult to the parathyroid gland.
Yes.
Symptoms manifest after 48 to 72 hours of procedure.
Yes.
Patient first earliest complaints of earliest symptom as perioral numbness or tingling.
Yes.
Then it can lead to paresthesis and tetany, which will also worsen to respiratory distress, which is the cause of death.
Okay.
The signs which we can see when we inflate the sphygmomanometer, we'll get to see Trocheus sign, which is the carpopedal spasm.
Okay.
And Chostek sign, which is the twitching of face muscle.
Yeah.
And for management, we have to monitor the patient and monitor the serum calcium levels and supplement with serum calcium.
Okay.
And permanent hypoparathyroidism happens in 1% of cases. For them, we have to give throughout lifelong serum, lifelong calcium supplementation.
Okay, very good. Yeah, this concept is important. And then minimal invasive video assisted surgery. Minimal invasive video assisted thyroid surgery. When we were undergrad, postgraduates, we were just using only incision here, remove it. But this is a very cosmetic. It has become very cosmetic. So people have tried many ways. So they are using transaxilla. They'll put ports from here and they'll just go here. Transaxilla via nipple, subareolar space. Retroauricular. From here they'll go into space. Transoral from inside the mouth. So many ways are coming to deal with this thyroid gland. Okay. The aim is, what is the aim in doing all these things? Aim? You can just open it up, right? Why to do all this, Jugaad?
Cosmetic and also post-operative hospital stay as well.
No, actually the post-operative hospital stay will increase with these things, but the main thing is to avoid skin incision. Okay, that is the main thing. So indication is only in less than 3 centimeter swelling only we can do. If it is more, we can't do it. Contraindications are large nodule. More than 3 centimeters is a contraindication. And thyroiditis, infection of the thyroid gland, you can't do it. But this is a failure actually. Not many people do this. We have we can close it nicely in such a way that the scar is not visible actually. Okay, just for completion's sake. And sometimes they may ask you this approaches also. See, transaxillary you can do, nipple, subareolar you can do, or retroauricular, transoral. 4 ways to do a minimal invasive video assisted thyroid surgery. So hyperthyroidism, hypothyroidism, it is more of medical treatment, but just I'll tell you what are the, you should tell me, medicine classes over, not over?
Not yet.
Not yet, okay. Physiology?
No.
We had a basics class.
Only basics. Okay. So, but you might have studied, right? For medicine, for surgery, for physiology, from our first year onwards, you should study this.
Yes, sir.
So, yeah. What are the various symptoms of hyperparathyroidism? What are the various symptoms of hypoparathyroidism?
Parathyroidism.
Or
Sorry,
thyroid.
hyperthyroidism and hypothyroidism. Thyroid, sorry.
For hyperthyroidism, it would be tachycardia, palpitation.
No, come organ
sorry.
wise. Yeah. First of all, yeah, you are telling about cardiovascular system. You remember like that. It's easy. First, cardiovascular, heart. Okay. What happens in hyper?
Increased heart rate.
Tachycardia, palpitation,
Okay.
excessive sweating.
Okay. No. Hyper in cardiovascular, tachycardia, palpitation. In hypo,
Bradycardia.
bradycardia, erythemia are seen. CNS in hyper. What will happen in hyper CNS? How will the patient be every time? He will be cool, calm, composed, or he will be anxious and irritated.
Irritated.
Anxious and irritated.
Be anxious and irritated here in hyper. Whereas in hypo, he will be dull, lethargic.
Dull. Yeah.
He will be dull and lethargic. Yeah. GIT,
Increased motility.
Increase weight as well in
Weight.
hypo.
okay. Diarrhea. Mainly, there will be increased motility leading to diarrhea here. And here, hypo, what is there?
Constipation.
Hypoconstipation. That's it. Yes. Okay. These are the main symptoms of hyper and hypo. You remember like this, system wise. In medicine also, when they tell you, just remember system wise. Cardiovascular, what is this side effect? How is the symptom? Hyper how? Hypo how? CNS, how is it? GAT, how is it? Okay. And some menstrual disturbances will be there. Menstrual changes will be there. Amenorrhea will be there in hyper. Menorrhagia will be there in hypo. It is reverse actually. So what is this? Causes plumber's disease. What is that? Plumber's disease?
Single nodular.
Sorry? What is plumber's disease? What is Graves' disease?
One hypofunctioning nodule is plumbers, and the whole gland hypofunctioning is Graves'.
Yes, very good. Okay. So then management. Coming to the management of Graves' disease, we are talking about Graves' hyperparathyroidism. We are talking about management of hyperthyroidism. So we have drugs to control that hyperthyroidism. What are the drugs? Anybody?
Carbimazole in pregnancy. Otherwise, we give methimazole.
Methimazole.
Or in crisis, we give propylthiouracil.
Propylthiouracil. Okay, very good. So we have 3 drugs. Punjab Medical College, 3 drugs. Propylthiouracil, propylthiouracil, methimazole, and carbimazole. Only 3 drugs are available to decrease the thyroid symptoms. Or we can give radioactive iodine ablation. Iodine, somebody was asking initially. Okay, this is done to ablate the gland. Iodine 131 is given for ablation of this gland. And finally, if it is not cured by drugs or radiation, we can go for surgery also. Okay. So these are the three things: drugs, followed by radioactive ablation, and finally by surgery. This thyroid storm and all this. Okay, Graves disease, management of Graves hypothyroid, Hashimoto's. Yeah, this management part is over, right? Drugs and all. So, and the timing, when to intervene before procedure also is important. So, a patient with hyperthyroidism is there. Hyperthyroidism. So, if you want to operate before 6 to 8 weeks, you have to give antithyroid drugs, non-selective beta blockers. Why are these non-selective beta blockers given? What is the example for it? What are the three antithyroid drugs I told you? What are the three antithyroid drugs?
Metronidazole, metamizole, and carbimazole.
Okay. So why are a non-selective beta blocker? What is the example for the beta blocker? Tell me.
Atenolol, propranolol.
Yeah, propranolol. Atenolol is little cardioselective. I want a non-selective propranolol. Okay, we will give propranolol because the patient will have tachycardia. He will have heart rate of 120, 140 before surgery. So we have to bring it down. So 6 to 8 days before only we will give this propranolol and all to bring this heart rate down. Okay. Yes, no?
Yes, sir.
Yes, sir.
And 7 to 10 days before we give lugalcidin. Lugalcidin drops. Earlier days they used to give lugalcidin. They decrease the vascularity of the gland. This toxic gland, if you just put a needle, or if you just incise on it, it will bleed like anything because it is toxic, hyperfunctioning nodule. So you have to decrease the vascularity by giving lugalcidin. And there is an entity called thyroid storm. Okay, if you don't prepare in this manner, this is the manner you have to prepare. The preparation should start 2 months early and 10 days before another treatment. If you don't prepare in this manner, inadequate preparation will lead to this thyroid storm. What happens if you don't prepare and you just operate on a thyroid case? There will be thyroid storm. The patient will have tachycardia, he will have dehydration, confusion, hyperthermia. Okay, so how to manage this? This is a life-threatening emergency. So you have to aggressively give IV fluids, cool the patient, give IV steroids, large dose of carbimazole. You would not give before, so you have to give it prior, before surgery also. Okay, so this thyroid storm is seen in inadequately prepared patient. Inadequate preparation. If the patient is inadequately prepared, then the thyroid storm will be there. Okay. Yes, no?
Yes, sir.